Thank you, Patty. It's now time that we can take questions. I'm sure with our excellent panel, there are many questions out there. So,
Linda Burns, Bolton. This question is for anyone on the panel. I am, as all of us are watching the transformation that's occurring in the healthcare delivery system, since most of the measures about the impact of credentialing on patient care outcomes have been hospital-based, what are your thoughts about in terms of truly, if we're going to get to a system of care that is a health system of care, not an illness system of care, how do we go about, since we're in this transition period where we're getting more of care being delivered outside the walls of hospitals, how do we not make the mistakes we did with measuring in hospital care as we go to measuring in community care?
I'll take a stab at that. One of the challenges that we have is that the information systems are not interoperable. They don't necessarily talk to each other. So as a patient moves from an inpatient to an outpatient setting, we're not necessarily able to track all that information. The closest we can get to that is if we look at health insurers' data. But even then, we're missing a lot of what's going on during that visit, that face-to-face encounter with a clinician. Along that way also is the need for measures in outpatient settings. And how do those really complement the measures that we're using on inpatient settings, or are they actually taking us in different directions?
I'd like to give that a try also, Patty Brennan. There's been some work done in the last 5 or 6 years at a collaboration between the IOM board and the National Academy of Engineering, led by Bill Stead and Bill Rouse, on trying to take a multi-level systems framework to health and health data and health care. And it appears and disappears. We're in the process of hopefully getting the final a paper out for open discussion, but happy to share it with you, anyone who's interested. I believe part of the issue is finding the link between what we do in the moment and what we do in life. And part of that link may be through population health connections to individual health. And it may also require us to think about certification as a episodic activity, not as a persistent monitoring. So if we switch the frame of certification from something that we do all the time to something that we do sampling and spot checks, bringing in some model ideas from quality engineering, I think we could see a really different way of detecting that trajectory across the continuum.
Just one other perspective too. So going back to having a common data model and starting with, what is the research question that we want to answer, and then what measures do we currently have, and we might not have the right measures yet. So starting with those and then figuring out, what are the data elements then that are required and where can we get those and who are the stakeholders that can help us to get that data and make sure it's maintained and available.
Jack Needleman. My question sort of starts where Patty just ended. Big data, we think Google, Amazon, and who cares if they deliver the right ad to me or the right movie recommendation? But we're talking about things that affect people's lives here. And repeatedly in the conversation, there was discussion of the need for a common credentialing data model, structured data, but recognition that much of our data in the HR, from the HR systems are not currently structured. And I'm just wondering how we are going to, what is your vision of how we evolve to where we have the data necessary to do the research, but also monitor the care that's being provided in terms of who's providing the care, what their credentials are, and so forth? Are we going to insist that the systems get more structured, that the data be entered in a more structured way? Are we going to do more data capture from streams of data, or from HR systems or EHRs that have lots of free text, and figure out how to organize that reliably and validly into structured data that's going to allow us to do the kinds of monitoring analysis that we want to do both in practice and in research?
So I'll take the first stab at that. That's a great question. You know, I think probably all of the above. So I think what big data analytics offers us are some of these newer techniques for aggregating data and recognizing patterns, doing data mining and recognizing patterns, so you don't always have to have structured coded data. I think that one place to start would be to identify a core set of, you know, by starting with research questions that are really important in this space, and then identifying what are the measures we currently have, what are the data that we need to populate those, using some of the lessons learned that Nancy talked about in terms of what's feasible, you know, and what can we use the approaches that are currently available, and then also looking outside at new approaches. You know, Patty talked about people wearing sensors and using more sensors, you know, so that we're not always depending on a clinician to be doing data entry, or we're allowing patients to enter data and we're using those as part of the solution. But I think that it needs to be incremental. I think we need to have partnerships with clinicians, vendors, and all the different stakeholders, so that we can build this data model and agree on, you know, what the path is.
I think that's, Patty, is a good definition for the future. I think where we are today is that we specify what we want, and people have to then go find it in their records, and which requires a lot of judgment and a lot of testing. It probably isn't as reliable, but it's where we're starting at the moment.
And Jack, I'd make a push for us really thinking carefully about sampling strategies as opposed to 100% tracking, because I think the barrier to 100% tracking is just way too high. And its certification is expensive. We believe it's worth doing. If it's worth doing, maybe it's better to demonstrate it through a sampling approach that's systematic. I'm not talking about casual sampling, a systematic sampling approach that might help us get the snapshot we need now. I don't have much hope for the existing data systems that are text-based to convert ever to a standardized term. Maybe some good natural language processing strategy will come along, but it doesn't look like it right now to me. So we need to think differently about how we're going to find the elements and pull them in.
Also, when you're talking about a starting point, there really is the necessity of definitions and models, and I think that we are looking at doing that with this workshop, but then also taking it to that next step and actually doing some research projects that are based off of that. I think when you look at the big database strategies, one of the things you quickly find is that these databases are not interoperable. And so I think when we discover that is working with those organizations and really saying that this is a need for these databases to be interoperable, so that we can actually look at, again, these questions, these key research questions that we're going to be discussing. Because again, right now, all these databases reside in so many different sources. There's so many different definitions that are used to bring them together to answer any of these questions. It really ends up becoming silo research. So what's going on in this organization, or maybe this system, or with this type of credential, but not really getting to that bigger issue of, does credentialing itself make a difference? And if so, what does that mean? How is that manifested?
Two-sentence anecdote. We found that wounded ostomy nurses were so distrustful of the electronic health record that in most of the hospitals in our pilots, they were keeping their own database.
And Spetz, University of California, San Francisco. I just have an observation for Nancy. I appreciate the work that you have done in trying to create some structure around the credentialing data collection. The National Sample Survey of Registered Nurses, when it was done in 2008, we tried to learn from the 2004 and actually get things like have a functional certification checkbox, because if you left it open-ended, people would list all of their life support and all of that other stuff. And so I think if HRSA ever does another national sample survey, they'll probably want to look at what you've done to guide them. I have a question for all of you. I'm pondering how health IT or just general data management systems could help us identify credentials and the value of those credentials in community-based settings, and what are the barriers to those settings. And I'm thinking of the public health nursing type credentials, the various sorts of case management credentials that may perhaps become more and more important as we move into more preventative care and more of a culture of health.
So I don't know the answer to this question, but I'll give you my informatics answer, which would be, again, going back to a standard data model and saying, okay, so on an organizational level, it doesn't matter what type of organization, what are the data elements we need to keep related to the individual nurse and to the different credentials that that nurse might have. So, you know, there's lots of different places we can pull the credentialing data from, but we have to have agreement on who the steward is. So is it going to be the credentialing organization, and then, you know, and then individual organizations can pull that, or will it be the organization itself? But this is part of that, you know, we talk about stakeholders and the importance of getting agreement with data models on who's the steward. That's why this is important.
I think it's important to recognize that you're dealing with a very different animal when you move into community. You don't have the employer relationship all the time. Sometimes some of our public health nurses are employed by their district or their community government. They have different incentives, different reasons to be willing to or not to share data. My sense is that the public health nursing community is actually working to build a credential type reference model, at least, to identify who's working in public health and what are the different credentials. Part of the challenge is that some of those credentials then move out of the control of the profession of nursing, and people get and I'm thinking now a little bit in case management, but I'm also thinking about in some of the water quality testing and some of our rural nurses are doing. So I think certainly to the extent that there is a super organization or a head nurse to pull people together, you have a channel for even communicating about the need for reporting and gathering information about certification. I looked to the enormous growth of care guides, spiritual escorts through your cancer journey, not to be disrespectful, the case people who said individual case management businesses, and I see a real need for us to start working with the commerce community in our states about what licensing for these businesses should look like and should require, and that may be a different pathway.
And I think, too, parodying on what's been said before, is that so much of this information is paper-based and it relies in file drawers. Or actually, if you want to make it even more difficult, it's floating around in people's heads. And so how do we take it to that next step? Also, when we look at what goes on in the community, it's not necessarily those just providing care and having a salary to do so. It's also the lay caregivers as well, who in many respects will probably never receive credentials. And so it's basically taking that knowledge and actually putting it into a digital format first and foremost. And what should that knowledge be? Who is doing what? Is that meaningful? So in other words, a lot of the care that resides in organizations is carried on by lay caregivers in community settings, and how is that differentiated? And so again, does credentialing make a difference, or does even licensure make a difference at that point?
Refund the National Sample Survey. And this was not a plug for Rescan, you know. And so, you know, it's refund. So because it reaches from registry lists, it reaches nurses and wherever they are.
So there are more and more organizations becoming our ACOs, and as a part of the ACOs, if they're using electronic health records, they are increasingly trying to engage patients in the efforts to put information in those electronic records. And might we not use that as a source of information?
I think it's a potential source. If you look at the advantage of something, for example, of telehealth, there's different telehealth technologies, and the information that's captured and then reported back to clinicians that aids then in care decision making. You also have to look at what is the motivation for those patients to report that data, and the sensitivity, or in many respects, the concern about how that data is going to be used. So while that is a viable resource, even if we look at patient satisfaction, a lot of the patient satisfaction we have is not necessarily representative of the patient population as a whole, but of a subset. And so if we can kind of continue that theme of what goes on with patients and what they're willing to report, is there incentive, is there a disincentive, and how is that information going to be used, we need to be mindful of that.
Linda, I'm really glad you brought that up because I think this is an opportunity for us to ask you administrators to fish or cut bait on the level of patient-entered data. Because right now, and Michelle knows this song really well, right now, patients are presented with portals that they are encouraged to manually type in lab reports from other facilities or type their last 3 bowel movements or how much food they're eating. And that's not part of their clinical record. It doesn't, clinicians can't access it. It doesn't get integrated. The data aren't standardized. So we will turn to you and say, great idea. Patients are amazingly willing. What they'll do if they believe it's going to help their care is phenomenal. And so if you can help us by break down that wall between the portal and the EHR, I'll be thrilled.
That was the point I was going to make. So it's a great place to start with patient-generated data, but if it doesn't mean anything if it's not integrated with our electronic health record that we take care of the patient at the bedside.
So we're doing a project right now at the Brigham where patients are entering their goals of care, their problems, and this is becoming part of the interdisciplinary plan of care. They're rating the degree to which they think the team is helping them to meet their goals. So this is for inpatients. It's patients and families in the MICU and patients and families in oncology. Now, to Rhonda's point, not every patient can do it or wants to do it. We're learning a lot about the patients who are willing to do it.
Yes.
So if the patient comes second, should the patient be certified and credentialed? Because if we're asking to put this information in, it's becoming such a part, and I'm checking to see if our portal runs into our EHR.
It doesn't. I can tell you, baby, it doesn't.
So, but I'm curious to see, the level of data that we get from patients today, Patty. I mean, that's a very thought-provoking question.
So don't pull a doctor on me, okay? Because what we hear often is patients will lie. And last year I was doing the ANA's National Nurses Day webinar, and I put up a questionnaire. What is the challenge of patient-centered care? And one of the options was patient will lie, and 62% of the nurses listening clicked that answer. All right, so we have a trust problem, and we have to work on that. We have a trust problem, and actually, I lied when I was pregnant. I never had that second. I never drank the whole time I was pregnant, and I didn't get on that scale either. So, so let me go to the bigger issue. Several of you in this room have written the phrase. I'm sure you have. Patient is a good historian. Right. I'm not saying stop take them, but I am saying we do always appraise the person's willingness to tell us their story. And Linda mentioned open notes, and I think we have to think about the fact the person's story is the person's story. It is their story. It may not be the same story that their mother would say, their sister, or that we say. It's their story of the moment, first of all. Secondly, if we're going to engage patients in trying to help us give better care and give less expensive care, they've got to have some skin in the game, and they've got to have some benefit from the game. So we have to, if we're going to do this, we have to give them incentive structures, support, and better care.
Other questions from the audience? Carol.
I'm Roy Swift from a new organization called WorkCred, which is an affiliate of the American National Standards Institute. One of the things that we're trying to do is work with health systems in regard to what do they say they're needing for the future in regard to standards and performance. Patricia Brennan, I was particularly interested in your comment that you looked at the preparatory materials for certifications, and this is an area that I've spent a lot of time in today. And I'm wondering if this isn't one of the issues that we need to explore too, is this developing the systems that continually update, because one of the things that the health systems are saying is that education and the credentialing system is not providing them the product they need. that there is a skills gap, just like we hear it in manufacturing. We're hearing it from the health systems in the United States too, that somehow the disconnect about what industry says they need, what education is producing, and what the credentialing organization is testing are different and not aligned. And I think it's time that we started looking at that credentialing process sort of at that three-legged stool that we talk about of academic and credentialing and clinical to begin looking at some of the credentialing issues we have. And of course, we know that as these new roles of patient navigator, transition specialist, community health worker, and nobody knows who they are or what they are they an additional skill identifier to a nurse or a physical therapist or a social worker? Are they a role? What are they in this regard? Because it seems like we're moving to a very blended type of healthcare, and certainly team competencies is one, but I think that's the other thing that we need to look at. And believe it or not, most of the certification bodies in this country do not do predictive validity. So we don't even know if the competencies that are measured by the exam really the person has them in the practice setting. And it seems to me that that's one of the first steps we should be looking at.
Oh, so I'll comment too. So the first time I came and presented for this committee in the winter, one of the things that I talked about as one of our barriers is that, you know, we don't have a standard competency in healthcare settings where we can measure how well the nurses are doing. You know, one of the problems we have with credentialing, you know, maybe we have data on nurses in magnet hospitals, but we don't have the same data in nurses in non-magnet hospitals. We do have, and I talked about the QSIN competencies. So QSIN is quality, safety, informatics competencies that are used in education. But once the nurses get to the practice settings, they're no longer used, but they would be quite appropriate because they would help us on a continuous basis, maybe the annual review, evaluate how well the nurse is doing relative to these things that we teach in nursing school or nursing colleges about the nursing process and about completing their job. And if we were able to do that, that would give us some comparable data across organizations about what nurses do and competency level.
One of the things that we have to think about is the issue of steps. So is that first step, that initial training, that formal education, is that second step indeed credentialing, or is it additional education? If you think about the education that goes on in the workplace, there is a continuous stream of educational programs that clinicians need to engage in, but there's also the patient education aspect as well. What is that minimal threshold to achieve, in many respects, I guess, the minimum outcome? And so what do we achieve for those optimal outcomes? Is it certification beyond licensure? Is it something that maybe we haven't even thought of to date? So again, looking at that issue of competency, is it truly manifested with licensure? Is it truly manifested with credentialing? Or is it manifested with something we haven't even approached?
I think we have time. Carol?
Earlier, I just wanted to say that, I'm Carol Hardigan from American Association of Critical Care Nurses Certification Corporation. I did just want to say that I've worked there for 16 years, and at the time I came to work for AACN, we already knew that 40% of our critical care nurses were no longer working within the traditional four walls of the ICU. So now it's an even greater number. If you have a heart attack now, you don't even get into the ICU. You're out on the progressive care unit. So, you know, we are really, acute and critical care is really being delivered out in the community. And long-term acute care hospitals, as you know, have critical care units within them. So I think, you know, going forward, it really is a lot about certifying the individual and then the nurse competencies match the patient needs wherever the patient may be. And I think there's a lot to be said for team certification as well. But I did just want to tell Roy that as far as certifiers go, advanced practice certification. We've been working on that since 2004 with the LACE model, so I think, we're kind of getting that together. And as far as our other certification exams, as far as education certification disconnect, we do certify those practitioners after 2 years of practice.
We have about 30 seconds.
Hello, I'm Martha Berggren from the National Board for the Certification of School Nurses in the University of Illinois at Chicago. And I'm wondering what sort of organization or process is in place for those of us who are not hospital-based to get in that data set and get in the core data systems, and what's the mechanism for connecting us with each other, with the long-term care nurses and the public health nurses, et cetera, so that we are ready when we go to these interoperable data systems and making sure that we're collecting the right measures in the right way.
Panel, does somebody,
Oh, me.
yeah.
We're moving into ambulatory settings as of this year. But at the moment, the first step is ambulatory settings associated with a hospital. So, but then we intend to go into the community after we learn lessons from ambulatories and hospitals. Yeah. Yes. And yeah, I know that's logically we should start with you.
I would like to turn your question around to a charge to the committee, which is to think about where should there be a repository of this information external to the institutions. We think about, not at Cerner, we think about, we've struggled with this for 15 years with the personal health records movement. Where should a patient's personal health record exist? Should we have a health data bank or not? But in fact, it strikes me that there's an analogy for nursing information also. People leave organizations maintaining the currency of we may get some assistance by a federated not-for-profit space in the sky where we could store the credentialing information across the disciplines.
Thank you. I predict there will be robust discussion over lunch. We will break for lunch now. We'll be back here at 12:15. And if speakers, planning, and standing committee members could meet in room 103, and if every other participant, we're inviting you to go to the third floor cafeteria. Thank you. 12:30. She said